cancer, whether you could combine both beta and alpha therapy, like most probably in the same patient that was asked, in the same sitting, or I'm not sure. But to put it in a different way, maybe I can put a question to Mike that when do you think which patients should go for in prostate, which patient should go for alpha, which patient should go for beta? I mean, which patient should go for actinium, which patient should go for lutetium, or rather, when a patient should go for lutetium and alpha, I mean, actinium? Is there a line drawing, or is there a, say, something in the histopathology or something in the gallium PSMA scan which would actually guide us to choose either lutetium or actinium?
So currently, the way one does it, and mostly how we does it, which probably that's also how you do it, it's really we go by the diffuse involvement. If somebody has got the extensive metastasis, diffuse skeletal metastasis, it probably from the bone marrow sparring, you probably then go for an isotope that has got a short path length, which is then an alpha, and therefore you are likely not to have a bone marrow side effect. And of course, if people have got oligometastasis or pure metastasis, then lutetium is actually probably the best way to go. And in that way, should there be problems of progression-free survival that is shortened and then you need to continue with therapy, then you still can continue with alpha therapy in that case. But also from the original question in itself, yes, I think the group in Bad Berka as well as in Munich, they have done tandem treatment of combining both alpha and lutetium in the same patients. As to whether now it's better than actinium alone, or it's something that will adapt, it leaves to be desired and to be seen further. Is there any benefit? Probably yes. Again, Heidelberg group also demonstrated relatively fewer patients that are complaining with xerostomia in such a setup. So I guess to take the dose of actinium slightly down and then combining it with lutetium, it would appear to work. But really, you could also argue that if you are having a de-escalation, that could be the approach. The jury's out as to whether it's really it's going to be better than when you are doing actinium alone or one of that.
Okay, thanks, Mike. I'll come back to a few of my other doubts later. We have a question here from Budiawan. Could we give lutetium PSMA to patients with non-functioning kidneys undergoing hemodialysis? So right now I only have Mike, so I have to ask you. Non-functioning kidneys undergoing hemodialysis.
The GFR, Mr. President, has to be really at least about 40. So the patient has to have a relatively preserved renal function. It is something if the patient has got one kidney that is not working and the other one is preserved. But if it's complete non-functional kidney, we have to work on improving the function, yes. The answer is if you improve the function, of course, we can end up treating like we have to wait first that the function at least the GFR is up to where we want, and there isn't any obstruction that we can see. If there is issues of, for instance, hydronephrosis as well, obviously you can also end up by giving things like Lasix, maybe say 13 minutes after the therapy to try and get the expression of the isotope a bit faster. So yes, but we have to increase the functioning to be up until a certain limit of acceptability. As soon as we have urea and creatinine that are really out of range, and we have the GFR that is very, very low, it is a contraindication by itself. We should avoid, obviously, working out of the bounds of what is recommended at the moment.
So will alpha therapy, you think, will be better in a patient with poorly functioning kidneys, or?
So far, we have had patients that have got, for instance, single kidneys that we have treated, and then the people that are really treating most of the lutetium therapy, as was presented as well during Richard Bum's talk. You saw that patient with one kidney. So depending on how you would have selected your patient, it might go back to what you asked earlier on of how what would be the criteria of first of all selecting the patient, either for beta or for alpha. So if you have selected already a patient for lutetium, could actually go ahead and treat under such, but if it is for lutetium, selection is the one that is important under such.
So Josh says lutetium DOTA can be given to patient with kidney dialysis. Well, yes, I would tend to agree with him because we have treated one patient not with dialysis but with poor renal function and a single kidney with DOTA, and the patient is still going well as far as renal functions are concerned.
Partha, I've turned some questions that came in through the day on the screen if you want to take a look at them.
Is Bexa still commercially available or do we make it? I think it's still commercially available. What do you think, Mike?
Yes, it is still available. Of course, it hasn't actually gone as what we thought it would be, but it is still available, unfortunately. Similarly to Zevalin as well is still available, but unfortunately, for some reason, they haven't actually picked up from what we actually should see them doing the thing. Probably it could be poor communication between us and the oncologist, because I do suspect there's a lot of indications for both either Bexa or Zevalin. Of course, the issues of which aid tracer to take, between which isotope to take, iodine or yttrium, between the two of them, I would imagine availability. It will be cheaper to take Bexa if you were to look at it from the economics point of view than Zevalin, of course.
So Bexa relative merits as compared to Zevalin. Do you have any personal experience, Mike? I don't have. We haven't treated any.
It's really the finance is not really. I think Zevalin, it's really obviously Bexa. The Zevalin has it's more data on it that actually shows good indications relative to Bexa. But I'm not. I can't recall a head-to-head study of such a thing. It's really they do have more or less. They are comparative in terms of their survival and disease control rate. Disease control rate is essentially the same. It's really got coming to what is available for the person.
How much is the cost of astatine therapy? Is it effective in lymph node metastasis also? Tadashi.
Yes.
Question for you.
Yes, of course. If it is iodine avid, it means it has sodium iodide symphoter function. So it also takes up astatine as well. So it will be also effective for lymph node metastasis, I hope. And another question is the cost. The cost is it's very good question. So to produce astatine, we need accelerator, and we need some cost for the production. But if we consider the refractory thyroid cancer patient, these patients are taking TKI treatment, and patient have to take TKI every day. So the cost, annual cost will be 7 million Japanese. So 70,000 US dollar. So the astatine therapy, so single injection, maybe it will cost 10 10,000 or 20,000 US dollar. I think. Yeah. So it is not higher than the usual TKI treatment.
I think the cost will also depend from where we are sourcing it from and which country it's going to. It will not be same in each and every place around the globe. But are you using astatine now in patients, or it's only pending clinical trial?
So we are now preparing for clinical trial, and we maybe we can start clinical trial next year. So it's still pre-clinical stage at this moment.
Okay. Thank you, Tadashi.
Thank you very much.
There's the two questions. Do you have experience in the treatment of non-prostatic tumor but 18 FPSMA positive lesions? I feel that the uptake of PSMA or the dose delivered will probably not be as much as in prostate cancer. So I'm not sure. Mike?
Yes, we obviously were wanting to try that if you are giving expression of PSMA, can you treat? But the problem is that in other tumors, there is no internalization. So you have a problem. And for instance, that you might actually not cause the desired effect. It probably will be for a shorter period of time. And from there, then the isotope will be there by itself, and then you might end up having side effects. For instance, if you have a molecule that is not going to be internalized, you might be looking at the shorter half-life. Say if you were to be able to use with bismuth, for instance, you could get away with it, but it is a bit of a problem to treat when there is no internalization. So the simple answer now is that it could help in terms of monitoring of therapy, identification of lesions, and for instance, indirectly, perhaps maybe speak to other things such as angiogenesis in, say, breast cancer, which is, we did image a patient with gallium PSMA, which would be the same as fluorinating PSMA. We could demonstrate that, I mean, there were some lesions that could not take on LG, but they took on PSMA. So the information we gave to the oncologists was that they could also try and look at whether if they were to use anti-angiogenetic therapies, perhaps it could be effective in those lesions. That's what it is. But in terms of theranostics, it's not really going to be something to be recommended at the moment when it's not internalized.
Josh, you wanted to have a take on that one?
I don't. Do you want to ask the questions about difference between the different types of PSMA molecules?
Yes. So next question is there any significant difference between the different kinds of PSMA molecules? 617, INT, and iPSMA.
We have used all of them, and we're also fortunately involved in using even newer ones, except the three that are really there. Because in terms of the one that is better known, it's 617 and all the international trials that are happening, multi-studies that are happening. INT, one does not, I've seen there isn't much difference, at least from when we utilize it. iPSMA, we have used a little bit of it, but now the difference is when you label them, will come into which one stays more and which one is more stable than the other. And then if you have to export it to other places, there might be slight differences that we have observed. That the PSMA might, so far it looks like it might longer together with INT, but iPSMA appear to have a little bit of, from our experience at least, that it's excellent levels, but then you might not want to have it long if you're going to have a late patients. You might want to reuse it sooner. And one of the other things, of course, depending on how you utilize them, if you are fractionating them with iPSMA and INT, they don't want, when you're labeling, you must immediately then take it back to the freezer. If you leave it, if you leave them outside, it would appear that you might compromise their labeling. So it's more on the technical side in terms of the head-to-head, whether the outcome and the achievement that you get from the patient's responses. Really, one would say they are really comparable at the moment. So the ones that are not mentioned in the question, the bigger ones, just ones labeled to albumin to try and reduce the side effect of the salivary glands, might be something else. to see. Of course, there's anecdotal data, but it would appear they might obviously circulate longer in the system and therefore be retained more in the tumor, and then therefore sparing the salivary glands. But the issue might be the kidneys might suffer. That has to still be determined in that way. So, but as of that, really, in terms of the outcome, the short answer is that doesn't appear like we are having much of a difference there.
I know
I would think essentially all the molecules will be the same as per biodistribution is concerned. So depends on the availability as well. Whatever is available with you, you can use that molecule of PSMA.
Kalivi?
So
Yeah.
basically,
No.
Yes, can I say something? So there are this.
Yes, Kalevi.
Pardon? You hear me?
Yes, Kalevi, go ahead.
Yep. So far there have been, to my understanding, at least 7 different PSMA molecules which have been used in the clinical imaging, and the key element is actually that how lipophilic, what is the lipophilic or hydrophilicity of the compound. You can modify this, and that's the thing. And then you play. It's actually in initial staging. What do you have in prostate? What do you see in prostate, and from that, and then the other essential element is of course urinary excretion. And then these which are there, and then if you want to look at the like liver metastasis, so that's also because if you have the res uptake, so then you have to play with that. But basically, it's as Mike said, but there are some few compounds where you have this. A little less urinary excretion, and that plays an important role.
Some patients respond to retreatment with lutetium PSMA. Why is there apparent progression then regression? I think she means that whether there is a flare phenomenon and then there is regression. Kalevi, you want to take that?
I didn't see the question. So flare response.
Some patients respond to retreatment with lutetium PSMA. Why is there apparent progression then regression? So I think she means that maybe initially, apparently after treatment, there is some progression, which gradually over a period of time, there is regression, either in the symptoms or the PSA levels.
Yes. So okay. So now there are multiple options because basically if you have because I've been treating like let's say that the first let's say 7 cycles and then second time like 4 cycles or something like that, and then it's actually if you kill it's depending what type of what is the phenotype of the cancer, how many different clones, because you cannot kill all the different types of clones, because every new metastasis site could be like start a new clone, and then the question is that what is the PSMA let's say PSMA uptake or the let's say turnover rate, because this is different it's actually the treatment is the better the more aggressive the cancer is, but it depends how these are distributed in a different manner. So sometimes you can continue, but sometimes you don't, and then you basically should stop or try something else if you see that it doesn't.
I think we agree with you, because even in our practice, we have seen that if you have an identical gallium PSMA scan, still some patients will some patients will respond well, other will not.
Yeah.
So probably there is what we call tumor heterogeneity in between them. And what we've seen is FDG scans come to a great rescue at that point of time.
Yeah.
If FDG is positive, more the FDG positivity, the lesser is the response. Mike, you agree?
Yes, yes, and of course, if really that's a very questioning thing. If it is FDG positive and discordant, actually, it might also not be better to treat that patient if we really are going to have more FDG and more lesions on it. But if it is discordant and less than PSMA, yes, at least the response is better. But of course, hopefully, it's more than the PSMA in itself. It's more than the liver uptake as well. Then we can treat.
In the same way. Now, when we talk of lutetium and actinium, now there is a lot of cost difference between the two. I know we cannot equate science and cost, but still, when you come to practice, you need to look into it. What I have seen is what response 4 cycles of lutetium give, the same response is replicated more or less with 2 cycles of actinium. So do you think we can give 2 cycles of actinium, and if there is response, give them a drug holiday? Or we do standard 4 cycles treatment?
That would be something good, because actually in our site as well, we give at least a minimum of 2 cycles in terms of actinium, even if the patient might have responded well with 1. So we consolidate with 2 at least, and then we can discharge them and or continue if they are still residual for the others. But the concept of the holiday, it's interesting. Do you give a holiday, or can you maintain them on a smaller dose as well? That's another aspect. But we have discharged lots of patients after 2 cycles. And then, of course, the day they come to, some have come back with recurrence or relapse, we have retreated them. But at least they will have had some 8 months, 10 months of nothing, especially those that responded extremely well and there is nothing, and that's good for them. More so if it's lymph node metastasis, those, they tend to really respond just like extensive lymph node metastasis. It goes away much quicker than if they have liver and or bone.
Okay, there is another question. This is from Budiwan. Should we decrease the dose of lutetium-177 PSMA in diffuse bone metastasis? Should we reduce?
I think diffuse bone metastasis is also both diffuse bone metastasis and diffuse liver. It's something that, unfortunately, if you're gonna give a suboptimal dose, then you also have a problem of not treating the patient well. We must treat, but it's important to actually protect the patient with steroids. So we give them prednisone for 2 weeks, and they do well, even with brain metastasis. Actually, 3 places: brain, liver, and diffuse bone metastasis. We definitely cover them with steroidal treatment for two weeks or so, and then that tend to work well, because if you're going to subdose them, it's also not optimal for the patients. Of course, there's also another study that is very good that is being shown now in Melbourne, that they have demonstrated no untoward effect for the diffuse bone metastasis. I know that earlier on I've said when we select, we tend to give diffuse to actinium and less metastasis lutetium. But however, that study of Hoffman et al., that demonstrates well that the patient have done fairly well under diffuse bone metastasis. It's a very good study that actually can be referenced under study.
Use of lutetium PSMA upfront before chemotherapy. I think this is the question which is being asked in all urological conferences, all medical oncological conferences, and even in our conferences as well. Do you think if we get a patient in a better performance status, it would be better response in that way?
Of course, especially if you can
say that chemotherapy has to be given, and patients who are not responding to chemotherapy, progressing on chemotherapy, they go for lutetium on compassionate grounds. That's what the guidelines say now. I know there is a trial which is going on, cabazitaxel and lutetium PSMA. So, but I'm talking of docetaxel, because docetaxel is not that toxic. So it's very difficult to convince the oncologist that whether you don't give docetaxel, you give lutetium PSMA first. Your take, Mike, then I'll ask Kaleri.
So I really think the sequencing has to be revisited. Yes, the oncologists are insisting on this, but we also have to convince them that we're doing something about the salivary gland, because these patients will live longer now if they have got xerostomia, and then we have really treated them Because really, if you look, for instance, if maybe one look at a study of, again, the Heidelberg, they've demonstrated a person with 5-year progression-free survival, not only overall survival, but progression-free survival that was treated before they could give chemo. The patient refused chemo and then opted to go for radionuclide therapy. And the patient is doing very well. And we have also demonstrated, of course, not lutetium, but on the actinium side, but those patients tend to have better overall survival, because in our setup, sometimes our patients don't end up having access to some of the chemo. So then that's why they come to us. So we really have to say what is available in each country, as well as what is actually the correct thing for the patient, demonstrating the OS, the PFS, and of course, demonstrating obviously the quality of life that we actually have to demonstrate that we are really improving the salivary gland. Because as one has said, even if we can say that we can do better than docetaxel, which I think we will, because docetaxel and Kava, they definitely will not give you much more of a OS than what we can do, but we fall short of the salivary gland that are not actually addressing adequately, which we will with time.
But quasi-taxol has a huge amount of toxic effects. I mean, the patients who come walking after cabazitaxel, they come in stretchers. So is there a way we can convince the oncologists that we should, before cabazitaxel, we should try lutetium or actinium and then go for it, or not give cabazitaxel at all?
Yes, the therapy trial that Hoffman is again busy with, it's going to be an important trial. And so far, when he presented at the ASCO meeting, he showed clearly it's actually ×2 better than what Kava does. So already, preliminary data, it's already telling them that you're going to do better. What we can work with them is that if there is a problem of now as you treat, because the patient can differentiate differently, and when you have to rechallenge, we might actually end up sending them for chemotherapy in the middle, but not to say that we should be forced to start with Kava or docetaxel. I think we shouldn't actually do that, but we should actually think about how can we complement when we actually have an issue of the patient no longer responding very well, or the lesions showing more FDG than PSMA. We then should consider a cabazitaxel or docetaxel under circumstances. We should really
I tend to agree with you on this. So we need to do, I think later on we need to do both PSMA and FDG for prostate cancer as well, like we do for PET-NET score in NET. And Kalevi, I want your opinion on this question.
Okay, so I have actually published. I've been able to treat patients actually with let's say stage 4 or T4 M1 disease in the first line, and actually the results were there. This is just anecdotal patients, like a few, less than 5. So the results were very excellent, of course, but this is not. I cannot say how this will be. Then the other thing, I've been actually trying to quantify precise dose calculations and precise tumor volumetric analysis, radiomix analysis. What happens after each cycle, and I have quite recently, this was not 6 months, 7, this was ICRT patient, and so we treated like 4 cycles. It was like we could treat, if I remember correctly, like 91% of the cancer burden for 4 cycles. Then we gave additional two cycles. So then the outcome was 99.8% of the whole lymph node, and so these are the patients who were heavily treated beforehand. So it helps. So we actually should measure precisely when to stop the treatment and how long we continue. So this then we know exactly what's happening. But this is very time consuming. So we cannot do this is not a routine practice, or unless you have a good method to do that. But it doesn't exist to my understanding. So it takes 2 days to calculate that where we are now, and so.
And what would be the combination therapy of abiraterone with lutetium? Abiraterone is supposed to upregulate the uptake of PSMA. Do you think practically it happens? Our inclusion criteria right now is once the patient has failed abiraterone, they have failed Xtandi, they have failed other treatment, then only we are giving lutetium. But can we combine abiraterone and lutetium PSMA? Because there is evidence that it upregulates.
Yes, yes. I mean, that should. Yeah. You know the our trial, this 6111. There was a bit, but was the history. So it should. It should be. I don't know the ultimate result. I don't know because I don't know the experience, elsewhere. But I have the feeling that it would help. Yeah.
Mike, any experience on this?
So on this, there's two things. I mean, it can actually have a negative effect on those patients that are not proven to be castrate resistant. But as soon as they're castrated, it's the opposite. Then it actually enhances. So one should establish first whether your patients are really castrate resistant or not. And that's what it's at least known at the moment, but that needs to be reestablished. That if it is really castrate resistant, you tend to have a benefit. That's what it's preliminary data, but that has to be proven really better. So it does two things. Before castrate resistance, you have a negative effect. You shouldn't then use it with this because it will reduce your uptake. But after that, it increases your uptake if it's castrate resistant.
Yeah, probably there is not much data, but it's worth trying. In the same analogy, there's another question: is there any information available about the use of lanreotide to increase the uptake of lutetium dotatate?
That's for Irene. Irene is there. I think Irene must have used it. Or I'm not so sure if she has tried. I've seen work from Irene about this, or speaking about lanreotide.
Yeah, I don't know because I have no experience. Probably I would think it's the other way around.
I've asked Irene to join to answer this question, but so far she hasn't turned on her camera to answer. So hopefully she'll answer in a second.
Okay, we don't have any other live questions at the moment. I'm just waiting for Irene. Irene, we could have some.
I don't know, Mesh used it. Maybe Mesh has used it. I see Mesh is online.
I can't see her. Irene, are you there?
Inhibits lutatate up. Yeah. Richard Baum told.
Even Richard is not here.
Yeah.
I will look to add Richard in 1 second as well.
Yes. So put him. I don't know about practice. I know just theory.
The only problem, of course, whilst we're waiting for them, it will be best to get their expert opinion. But on imaging only, we have had problems sometimes when we actually have to use it just plain on imaging. You would actually want your patient to be off it before you can actually scan. So now if you look at the imaging versus the therapy, so should probably be the same effect, but I'll hear what Rich and Irene say.
Sorry, so, okay.
Hello everyone.
Hello.
Online now.
Hi, Richard.
Okay, so lanreotide inhibits, of course, the uptake of DOTA-TOC and DOTA-TATE because it's an agonist and inhibits 3 out of 5 somatostatin receptors, also mainly subreceptor type 2 and 3, which are the most important for DOTA-TOC and DOTA-TATE. So lanreotide is not enhancing, it's actually reducing the uptake, especially if it comes to therapy. So there are some conflicting data on imaging because although uptake in the liver, in normal liver is reduced by many somatostatin analogs like sandostatin or also lanreotide, which is also called somatoline. And then sometimes small lesions can be even better seen under sandostatin therapy using PET-CT. But for therapies, there are very clear data that the uptake is inhibited and should be paused for at least 4 to 6 weeks before starting radiopeptide therapy.
Yeah, I think we stop it for 4 weeks at least. So it should be 4 to 6
Yeah.
weeks.
Exactly.
Yes, and what we do is that if we're having adjuvant, then immediately after, so within 5 days after administering our lutetium, they would administer the lanreotide. So at least there's enough time for us for the next treatment, and that we found does not have any effects on the treatment once it's been given.
Actually, I recommend to wait at least 1 week or even 2 weeks before administering cold somatostatin analogs, because if you look at the internalization of these compounds, the lutetium or also yttrium labeled DOTA-TOC or DOTA-TATE or whatsoever is taken up into the cytoplasm of the cancer cell and remains there for a very long time. If you do lutetium scans, you see even after 3-4 weeks, you still see the lutetium sitting in the tumors. Now, if you give the cold analog, it's also taken up in the tumor cell and replaces the hot labeled compound. So I think it is better to wait at least 2 weeks or even 4 weeks before starting the cold therapy. Anyhow, the interval between cycles is 8 to 10 to 12 weeks. So there is no problem if you give in the interval the cold, but you should not give it after a few days. You should wait at least 2 to 4 weeks before doing that.
Yeah, I think the actual thing is that actually, because I did some calculation, but this is a long time ago, it's like 15 years ago in Uppsala, and it is actually a matter of the concentration and matter of the number of atoms and how much this
yeah, but this is exactly, excuse me, Kalevi, this is exactly true. But yeah, you are giving 120 milligram of lanreotide, right, yes, for the somatoline, and you are giving 200, 300 microgram of peptide for the therapy. So yes, that is exactly the reason why I say you should wait.
Yes,
because the body is overwhelmed with a cold compound, and then it reduces the intracellular uptake of the labeled compound. That's my argument.
Exactly, but I wanted to hear the numbers. Yeah, thanks.
Yeah.
I was just wanting to ask about, again, looking up the DOTA-TATE, DOTA-TOC. Any of you, Rich and Irene and Partha, probably maybe Kalevi as well, have you used actinium DOTA-TATE?
Yeah. We haven't used it yet, but one group in India is using actinium DOTA-TATE. And
yeah, I mean, we were the first in the world using actinium DOTA-TOC many years ago, and there was just a publication, I think, from the Delhi group on the actinium DOTA-TOC or DOTA-TATE. And we yesterday had a meeting here in Germany, the NEN symposium, which is organized by Novartis with 300 participants. And there were exactly, actinium and alpha PRRT was a big topic to be discussed. And in our experience, in my time in Bad Berka, we performed more than 80 actinium DOTA-TOC treatments in patients resistant to lutetium DOTA-TOC or DOTA-TATE or whatsoever. And our very interesting finding was 2 things. First, some patients still respond to to actinium, to the alpha PRT, even if they are resistant to lutetium or yttrium. And the second is that the toxicity was extremely low. Many of these patients had very widespread metastasis in the bone. And my fear was that if we are using an alpha emitter for treatment, that we will see bone marrow toxicity, but exactly this did not happen. So I think it's very, very encouraging. And if you look at the late data with lead-212 presented from the group in Texas, in Houston, and also some preliminary data from Iowa in animals, you see that alpha emitters are probably much more efficient than beta emitters also in neuroendocrine tumors, similar to what we have seen in prostate cancer.
So which indication should we use actinium dotatate? Lutetium failed or upfront? Or
no, I would say first use what is approved, okay, and what is in science published and confirmed. So the first step would always be to use lutetium dotatate or DOTA-TOC. It's up to you what you are using, but lutetium dotatate is approved by EMA and FDA, but we are still using DOTA-TOC. Homemade, which I think gives you more flexibility and can be really used for personalized therapy, whereas dotatate is delivered by AAA or Novartis, and you have a fixed dosage, fixed activity of 200 millicurie, which you have to inject into the patient, which is not what I understand under personalized therapy. But the first step would always be lutetium, and then in a second step, if there is resistance and no other therapies available, as a last resort, so to say, one should use actinium, which, by the way, is only limited available. It's only once a month and only to a few centers in the world. And I know from ITM, who is providing the actinium, that the amount gets more and more limited.
I also agree. We have used a little bit of actinium dotatate. So, and then it was after lutetium when they were not doing well and we didn't know what to do with them as well.
No more questions.
Josh was writing a message. Josh was writing the message that we are finished.
No, he's saying you're welcome to take a few more questions, but we are, whenever you're ready to, close the first day. Bartha, it's up to you.
Don't see any more questions. Do we have anything else to discuss?
Irene, do you have anything you want to add in now that we can see you?
Hi, Irene. Good to see you. So from a far distance.
I can't see Irene.
I can't. I just did. Oh, now I see her.
You need to turn on your microphone, Irene. Or that part's not working. We have your picture, but not your microphone.
You need to unmute yourself.
She's unmuted. It's just her. She's having computer challenges today. Let's see if this comes in.
But
what did you all think of the first day?
That gives me the opportunity to thank again all the many people who were involved in establishing the technique and the technology of this virtual conference. I think especially Josh, you have done a fantastic job in getting all this together and in organizing all this. And I know there are many people behind the scenes which are actually contributed to making this a success. I have seen many of the sessions and it seems to be running extremely well.
Yes, first day was entirely excellent, very good content, and I think even the attendance was quite reasonably good.
how many attendees we had at the maximum?
We have over 300 people registered. I did not stay up through the entire night to see where we peaked out, but there were several times we came close to 100 people in a session. So I will have to look at that later and provide and see how many hours of data we have, of things we do. We potentially have one question from the audience. Let me see if I can get over there and find them 1 second. I see someone has their hand raised real quick. Daya, do you want to talk?
I probably will have to leave in a short period of time, if it's okay by you, Mr. President.
Yes, sure.
Yes.
I think we should also call it a day. It has been a long day for all of us. And dinner time in India, early morning.
Hello, Josh.
And potentially breakfast time in California.
Yes.
Okay. It's a very cool afternoon. It's a very cool afternoon here in Germany. I'm sitting in the garden with as you can see, you know, with some warming clothes here.
Yeah.
I had sitting in a virtual garden or a real garden?
No, this is virtual. No, I'm in my real garden, but the background is virtual.
The picture is virtual, yeah.
The picture is virtual, right?
We'll
I think
see.
you must be happy with the success of the meeting. Congratulations to you.
We'll see you everyone tomorrow.
Thank
Okay.
you, everyone.
Okay, have a nice evening, everyone.
Fantastic
See you
job.
tomorrow. Right, bye-bye.